This is accelerated surgery versus standard care in hip fracture, hip attacks trials. Okay, a little bit of the introductions. Worldwide, more than 1.5 million adults have hip fracture each year. So patients with a hip fracture undergoing surgery have higher risk-adjusted mortality than the patients undergoing elective total hip replacement surgery, suggesting that hip fracture itself increases patients' risk independent of the surgery. The patients with hip fracture are likely to be elderly, they have multiple comorbidities, and sometimes may be dependent on their daily livings. Hip fracture itself results in many negative impacts to the patients. It results in pain, immobility, and activates the inflammatory, hypercoagulable, catabolic, and stress state to the patients that will precipitate medical complications. Therefore, accelerated surgery can reduce time the patient are exposed to these negative physiological impacts and subsequently might reduce the risk of these complications. Hence, the hip attack study aimed to determine whether the accelerated surgery, which means the surgery in less than 6 hours from the diagnosis for hip fracture patients, was superior to the standard care in reducing death or major complications. This is the methods of these trials. It is an investigator-initiated trials, a randomized control. We include patients with age more than 45 years old, but diagnosis of low energy mechanism hip fracture and that require surgery. Those patients who take therapeutic anticoagulant without available reversal agent, and those sustain a periprosthetic, open or bilateral fractures, and those who required emergency surgery for another reason were excluded from the trials. Once the patient were recruited, the patient would be randomized into one of these groups. The first arm is the accelerated surgery arms, with the goal of surgery within 6 hours of hip fracture, and the second arm is the standard care. The co-primary outcomes at 90 days follow-up that we are looking at is the all-cause mortality and major perioperative complications, which include the composite of mortality and non-fatal myocardial infarction, venous thromboembolism, pneumonia, sepsis, stroke, life-threatening or major bleeding. The hip attack patients recruitment was started in March 2014. A total of 2,970 patients were enrolled at 69 centers across 17 countries. More than 99% of the patients completed 90-day follow-up. This is the table showing the demographic characteristic of the patients. The baseline characteristic and details of the surgery were similar between the groups. The participants of this trial were mainly elderly with the mean age of 79 years old, mostly women. Regarding the medical history before the presentation of hip fracture, more than half of the patients had hypertension. 1/3 of the patients needed assistance in activity of their daily living. About 10 to 20% of the patients had diabetes, dementia, and resided in nursing home. Most of the patients presented with an intertrochanteric fracture, about 52%, and followed by femoral neck fracture, and then small proportion of the patient presented with subtrochanteric fracture. In terms of hip surgery performed, about 60% of the procedure were open reduction and internal fixation. Others are arthroplasty. This is the median time to surgery for each group. It was 6 hours for the accelerated group, and for the standard group, most surgery were performed with a median time of 24 hours. Hence, the median absolute difference of 18 hours between the groups. These slides show the primary outcomes of this study. We can see that there is no difference between the two groups in terms of mortality and composite of major complications. This is the secondary outcomes that we are looking at. On this table, there were no difference between the groups. Listed here included vascular and non-vascular mortality, myocardial infarction, congestive heart failure, atrial fibrillations, venous thromboembolism, life-threatening and major bleeding, pressure ulcer, pneumonia, and new residents in the nursing home. However, fewer strokes occurred in the patients assigned to the accelerated surgery than the standard care groups. Delirium was less common in the accelerated surgery group. Also, fewer patients in the accelerated group had infection without sepsis. When we look into details about the types of infection, fewer patients assigned to the accelerated group had urinary tract infection compared to the standard care groups. For the tertiary outcomes, which include the orthopedic outcomes such as hip reoperation, prosthetic hip dislocation, implant failure, periprosthetic fracture, and surgical site infection, there is no difference between the two groups. The patients allocated to the accelerated group were faster to mobilize and faster to stand and full weight bearing after the operations. With regards to the time from randomization to hospital discharge, the accelerated group patients were discharged earlier than the standard care group, with absolute difference of 1 day. Besides, the patient in the accelerated group demonstrated a lower incidence of moderate to severe pain on day 4 to day 7. Next, we will look at the a priori subgroup analysis for the 90 days mortality. The effect on the mortality did not differ across the subgroup for time from fracture to hospital arrival. The same goes to the subgroup analysis based on the list of acute medical conditions in which the effects were consistent across the subgroups. For the co-primary outcome of major complications, the subgroup analysis based on time from hip fracture to hospital arrival demonstrated a significant effects. These analyses demonstrated that the hazard ratio for major complications decreased as the time from hip fracture to hospital arrival increased. Post-hoc subgroup analysis for 90 days mortality on the basis of whether the patient had an elevated troponin level before randomization showed a statistically significant interaction, suggesting that patients with an increased troponin at baseline had a lower risk of mortality with accelerated surgery than the standard care. Significant interaction also demonstrated for the co-primary outcomes of major complications. Other post-hoc subgroup analysis for the co-primary outcomes based on type of fractures and type of surgeries consistent across the subgroups. Also, subgroup analysis for the expanded list of acute medical conditions also demonstrated consistent results and no evidence of harm with accelerated care. So what is the conclusion we can get from the hip attack study? Accelerated surgery did not reduce the risk of co-primary outcomes of mortality and composite of major complications compared to the standard care. There is also no evidence of harm even in the subgroup with acute medical conditions. In addition, the accelerated surgery compared to the standard care resulted in a lower risk of delirium, urinary tract infection, moderate to severe pain score on days 4 to day 7, a faster mobilization, standing and full weight bearing, and have a shorter hospital stay. Accelerated surgery also demonstrated a mortality advantage in patients with elevated troponin before randomization. The important implication to us from this trial is that accelerated surgery for hip fracture is feasible and safe. However, it needs to balance with the logistics and resources required for accelerated surgery. The early surgery implementation is a team effort and often a multidisciplinary team members is required. This result of the trial is published in Lancet, and this is the writing committee who contributed to the manuscript. With that, thank you very much.